speed now.
Oh, probably this summer we'll open to tours. We'll bring you by.
Okay.
Was that self-incrimination on your part, Jeff? Did you just let us know that you might have been speeding in that neighborhood?
Well, when school's out, you don't have to go the 20 or 25, whatever it is.
It is.
So I guess in a way, yes. Okay. Well, I think it's time for us to begin our meeting. And so I will call to order the March, or excuse me. That's something else. Yeah. The April 6th meeting of the Oregon Educators Benefit Board on a virtual basis. And let me start off, since trying to justify the number of people in attendance, let me just take roll quickly. Robert Young.
Here.
Bill Grout.
Here.
Bonnie Luisi.
Here.
Susan Miller.
Here.
Susan Reike-Smith.
Here.
Good. JJ Schofield.
Here.
Reed Scott Swalbach.
Here.
Bob Stewart, yes. And Tom Siltabo.
Here.
Fantastic. Thank you all for being here today. First order of business is approval of the meeting minutes of the March 2nd meeting. Any comments? If not, we'll go to vote. Is there a motion?
I move to accept the minutes from the March meeting.
Okay, it's
Second. Susan Miller.
second. I think on this one, just raise your hand and hold it for a minute so we can count it. No, with your with it, a little deal down at the bottom there. So Rose can get that.
Where's my hand?
Here's my hand.
Hold on.
You're done? You got it, Rose?
Yes,
I can't
but
find
Jeff,
my
that
hand, but
doesn't
I'll say yes.
that doesn't record.
Okay. Is there?
But it's unanimous.
It's unanimous. Good. We'll move on. Thank you. Do we have Heidi Murphy in attendance yet?
Yes, I'm here.
Great. Okay, Heidi with an OPDP transition update.
Yeah, so good afternoon. My name is Heidi Murphy. I'm the operations manager for the Oregon Prescription Drug Program, and we provide the pharmacy benefit program in collaboration with Moda Health for OEBB members enrolled in Moda Plans. Thanks for allowing me the time today to provide an update on the status of our transition activity. And also joining me today in this discussion is Robert Judge. That's Moda Health's Director of Pharmacy Services. He's going to be available to answer any questions concerning the status of our transition, should you have anything that requires any deeper clarification. Can you go to the next slide, please? We're going to cover the topics outlined here on the agenda, and I'm going to be pretty brief to ensure that there's enough time to answer any questions from the board. OPDP is going to start a new agreement for the services that we provide using Moda Health beginning January 1st, 2022. The new agreement includes several new elements that I'm going to cover in order for the board to make a decision moving forward. Next slide, please. I just want to give you a little history. First of all, OEBB joined the OPDP program, which is part of a multi-state collaboration called the Northwest Prescription Drug Consortium in 2010. Joining OPDP allowed OEBB to benefit from significant price advantages that the Northwest Consortium provides. Moda Health has administered the OPDP program and provided the pharmacy benefit services for the program since 2006, when the consortium was created. As a state entity, we're required to conduct periodic RFPs to ensure that we provide effective stewardship of taxpayer money. And our most recent RFP was completed in 2020 with an effective start date beginning January 1st, 2022. Moda was selected as our administrator again as the outcome of the RFP, and they'll be retained in that role for the next 5 to 10 year contract cycle. All the services that Moda currently provides to the OEB members are going to continue, including pass-through drug pricing and fixed administrative costs. Contract improvements include more aggressive pharmacy network financial guarantees and additional service options. The significant change in the new agreement is that Moda is changing its subcontracted back-end pharmacy benefit manager from MedImpact to Navitus Health Solutions. And this is a change that we're super excited about, and we previously shared this good news with you. And Moda is currently executing on that transition plan. In order for OEB to operate under the new OPDP contract using Moda, OEB will need to complete a new pharmacy contract, and that's what we call a participating program agreement, or a PPA. Next slide, please. This diagram helps explain what I meant when I said using the back-end pharmacy benefit manager. The new OPDP agreement requires Moda to transition pharmacy benefit managers from MedImpact to Navitus. Services involved in this transition would include the claims processing system, pharmacy network, and traditional PBM rebate management. And these services are depicted in the purple and orange boxes that you see beneath the triangles on the slide. As the benefit administrator, Moda is going to continue to provide all the client and the member-facing pharmacy benefit management services today that they currently do. This includes their clinical programs, which would include formulary management, utilization management, and prior authorization, member services, including local support services, the member call center, and open enrollment support, as well as their specialty pharmacy services at their local specialty pharmacy, Arden Health. While there's going to be some changes for members, we expect that there's going to be minimal impacts. Next slide, please. This slide summarizes the most important changes occurring as a result of the new OPDP contract. As you can see, I've mentioned most of those. The couple things that I haven't talked about are the administrative fee options. There'll be a new option for per member per month, as well as the per paid claim basis. And then certain previous fee options are now actually included in our administrative fee. An example would be the pharmacy audit recoveries. Next slide, please. So an important consideration for OEB is the timing of the new OPDP agreement start date and the start of OEB's benefit plan year. OEB's benefit year runs October 1st through September 30th, while the new OPDP contract runs on a calendar year basis starting January 1, 2022. So under certain circumstances, the OPDP program we can provide available, we're able to accommodate a different start to OEB's benefit plan year. And this slide depicts the transition timelines that coincide with either of the start dates. So we're confident that Moda's team's transition can meet this go live date with either the January 1 date or the October 1st date, whatever the OEB decides upon, the OEB board decides upon. Next slide, please. And as I mentioned, there's not significant changes that we expect with this transition, but with any transition, there does come some change. So I just want to stress that neither OPDP or Moda has a preference in OEB's decision that you're going to make, as there's potential impact on these elements depending on the date the OPDP contract becomes effective. Advanced communication outreach, and also in some cases grandfathering of certain provisions may be applied to ease the impact of the transition, regardless of when OEB transitions. While we're preparing for a January start date for the new agreement with Moda, we can work with OEB to accommodate a start date requirement that might be different. Next slide, please. Depending on the start date required by OEB, this slide is intended to outline the actions required to make the new OPDP contract effective in a new PPA. A January 1st start date is the easiest method to administer, as it has the new OPDP agreement start upon termination of OEB's existing PPA. We'd require that the new PPA be executed before January 1, 2022. There's an alternative to have the new OPDP agreement coincide with the start date of OEB's 2021-22 plan year. OEB has the ability to terminate its current PPA without any penalty at any time to achieve this. However, in order for the new OPDP agreement to be used by OEB before 1/1/22, OEB is just required to notify OPDP and Moda as the OPDP administrator in writing that its needs can't be met under the terms of its current PPA. If this scenario is what OEB chooses, after we receive your formal notice from OEB, we just require that the new PPA be executed before October 1st, 2021. Next slide, please. So in summary, OPDP and Moda are continuing to prepare for contract transition effective 1/1/2022, and any change from that timeline just requires an action from OEB. Moda has already started the briefings with Willis Towers Watson about the new OPDP program and will be available to make periodic updates on the progress of the transition. And that concludes my formal remarks. I just want to open it up to see if anybody has any questions of us.
And if I could just jump in really quick, just with a note from staff. We've met and talked with OPDP and Moda, and we really think to minimize member disruption, if we could take advantage of that 10/1 start date, it would be a lot easier on our members. And I don't really see any major issues with it, but if there's concerns, definitely please express them.
Ali, this is Reed, and how do we know which pharmacies might be dropped off?
Well, I think Heidi, that would be a question for you.
They're conducting the analysis right now. It's not quite completed. Robert, do you know when that might be finished?
Yeah, so, and this is Robert, Judge, thank you, Heidi. So the implementation plan has, a number of kind of work streams that are proceeding, one of which is a disruption analysis on the pharmacy side. That'll be done in the summer timeframe. We're really confident because we're using, Moda's already transitioned most of its commercial business, all of its commercial business onto Navitus as the back end. And so we've contracted most of those pharmacies already. I expect if there's any disruption, it'll be very, very slight. And part of our work stream is to make sure that those non-contracted pharmacies are reached out to and we have them contracted into the network by the start date. So that'll take effect in the summertime.
Great question.
Maybe I could ask another question of Robert, just along that same line. Are all the same major chains included?
Yeah, so in this new agreement, we have two network options. The network option that OEB uses today, which is formerly called the Pacific Value Network, that is a limited network that excludes, well, it does not include Walgreens. Walgreens elected not to participate in that network. That network configuration is going to continue in the new contract. There's also an option for a broad network, which includes all pharmacies, all the major chains. The network guarantees on that are less aggressive. But you have two options. Our current thinking is that you'd want to continue on the network that does not include Walgreens from a pricing perspective.
Okay. Any other questions? JJ.
I don't really have a question. It's more of a comment. As it relates to timeline, I trust Ali as our director and subject matter expert in his assessment. So I'm in favor of going with October 1st. I'm also in favor of the more restricted network, although I generally like expansive networks when possible. If there's a cost differential, I think our members prefer the lower cost.
Would you like to restate that in a motion?
Sure, I move that we approve the October 1st start date of the new contract.
Is there a second?
Bonnie.
Second.
So, go ahead.
Okay.
Tom, second.
Moved and seconded. Let me go down the list here. I'll start at the bottom this time. Tom Siltabo,
Yes.
Bob Stewart,
Yes.
Reed,
Yes.
JJ,
Yes.
Susan, Reiki Smith,
Yes.
Susan Miller,
Yes.
Bonnie,
Yes.
Bill,
Yes.
Robert.
Aye.
Thank you. I guess I don't have to vote. All right, it's the motion's passed. Thank you for briefing us.
Yeah, you're welcome. So who shall I work with to get the formal communication?
That'd be me, Heidi. Thank you.
Okay, great. Thanks. I appreciate your time today.
Likewise. Okay, because CIAO has a recommendation that could have some impact on our renewal, I'd like to move the CIAO update up and do that next. Tom?
Yes. And Rose, if you could get the summary from our presentation, the cost and utilization. Yeah. Okay, so we discussed 3 different issues at CIAO today. First was the annual performance report that looked at utilization and cost. And there's, I think, 4 slides that I'm not going to go over in detail, but I recommend the board to look at. The first page shows what's happening with membership, and the key changes are in I think the 3rd big bullet down, where it says key benefit changes implemented in 1920 plan year. We saw the transition from the Summit Synergy and PPO plans into the options of Moda 360 and the CCM or non-CCM. And when you combine the Moda members who are now part of their CCM, coordinated care management, plus the Kaiser Permanente program, where 3 out of 4 OM members are in some form of organized systems of care, and we think that that's excellent. The other main issues that happened were, 1, we added a fertility benefit. We will start seeing data about how that's been used over the next 2 to 3 months, but we'll have a formal discussion a year from now. And then there's the impact of the reimbursement cap of 200% of Medicare for inpatient and outpatient hospital charges. Next slide. Important issues here. I want you to look at the bottom right where it shows performance. There's use of services. On the bottom, you'll see Moda and then Kaiser, and then the benchmark. That's for inpatient admissions, ER, and office visits. And both are show a slight decrease, inpatient and ER, for both Kaiser Permanente and Moda. Then when you look at office visits, a slight decrease with Moda, slight increase with the Kaiser system. Interestingly, when they looked at office visits, people in the CCM program were significantly higher than the Moda average. In fact, very close to what you see with the Kaiser program. Next slide. These are the, I want you to look at the bottom two, so the per member per year total cost. And this shows the change from the 18-19 plan year to the 19-20 plan year. And you'll see Moda's had a 6.3% decrease in cost, with that essentially being all inpatient. If you remember from our discussion last month, pharmacy went up slightly, and then you see the Kaiser decrease at about 1%. On the bottom right side, cost share per member per year. This isn't premium. These are copays and coinsurances and deductibles. So you see Moda, which is in the purple, going from 23% of the total cost was paid out of pocket by members. That dropped in the last plan year to 22%. The Kaiser Permanente numbers went from 9 to 10. So remarkable stability. Next slide. These show you the conditions. There's pretty significant overlap. And in terms of percentage of costs, cancer represented 8% of Moda's costs, 7% of Kaiser's costs. Osteoarthritis was present for both of the, diabetes was present for both of them on their lists. And then around high cost claimants, these are defined by people who have a 50,000 or more in claims in the plan year. You can see cancer represented about a sixth of those people. Next slide. And this is the, again, the summary, the impact of the care initiatives of moving to coordinated care plans. We increased from 57 up to 75%, which is what we want. Coordinated care office visits are increasing, another thing that we were hopeful to see. Looking forward, obviously, the impact of COVID is present. We've been discussing that all along. We're going to be talking more about centers of excellence, particularly in regards to musculoskeletal conditions, and we're going to be talking more about that. And I already mentioned the fertility benefits. So that was the summary. Good information, great conversation. Basically, the two plans are stable and performing quite well, and that the issue that's still out there has to do with impact of COVID and what type of bounce back we get. Now I'm moving on to we dealt with two of our wellness programs, and the first one had to do with what started as Healthy Team, Healthy You. It still has that name, but it's had different providers of that service. Several years ago, Stay Well bought Healthy Team, Healthy You, and the product that they provided was improved. And recently, WebMD has bought or merged with Stay Well, and they have this new product called the WebMD One platform. Wonderful collection of both lifestyle and chronic condition. They use onboarding surveys to personalize the opportunities for members who choose that. They have digital coaching. They deal with daily habits. The digital coaching has 16 different programs. 28-day lifestyle programs, and 84-day chronic condition. They have wellness challenges. They have a full-time coordinator who is in the past was face-to-face worked with entities, now has been doing that virtually. That person helps and works with the champion networks that we have at our entities. The WebMD have developed a wonderful data dashboard that will show engagement. So everything that they're doing is getting better and better. They even are including 100 hours of custom communication support, something that we in the wellness committee, we worked at trying to figure out how to improve that and to enhance it. So the issue has to do with pricing. The community standard for this type of intervention or activity is a per eligible participant per month charge. They are recommending a 0.25, essentially a 25 cents per eligible employee participant per month, which turns out to be a 300,000 per year charge. If you look back at what we have spent with Healthy Team, Healthy You, over the last 4 years, it went from about 240,000 in the year, about 300,000 during the first half of COVID. It dropped to about 110,000, and it's significantly less than that in the first several months. The WebMD is interested in really getting involved with working with entities, working with individuals, really boosting the communication, and and yet the CL members were stuck on the fact that it's a pretty high cost when we don't know what participation is. OEB staff had talked to WebMD staff ahead of time, and they are definitely willing to come up with performance guarantees so that if indeed they aren't meeting the numbers that we want in terms of participation, there would be some rebate of that fee. So we're going to be presenting to the board probably in June what that final product and cost look like, but that in general we're very pleased with what they are recommending. We just need to have some due diligence in terms of the financials to make sure that we're getting what we're paying for. Any questions about that issue? Otherwise, I'll move on to the Weight Watchers discussion, which actually requires board decision. Okay, Weight Watchers is enhancing their program with two different options. The first one is something called Weight Watchers Digital 360, which is an on-demand coaching app that's obviously digital, and it has many of the things that are already present, but I think the greatest feature is that as compared to the workshops and other digital activities, which are set in time, people have to adjust their schedule to be able to utilize it. This is something that's essentially an on-demand digital coaching around activity, healthy eating, and all the other components of Weight Watchers. And they are, with that additional offering, the cost for their program for the next 2 years represents about a 5% increase in cost. CL thought that it was appropriate and it is one of our most highly sought after and utilized wellness programs that we offer. So the board will have to agree to the pricing structure. I don't have those numbers right in front of me. Maybe Ali, you can get those if so that we can get it into a motion. But the other program that they are going to be they're rolling out now and offered to us for 2 years at no charge was Weight Watchers for Diabetes, and it is a diabetes coaching program that involves certified diabetic care and education specialists who work individually with people, establishing long-term relationships with goal setting, plan development, and then check-in and modification. They focus is managing the weight as compared to health plans, quote, managing the conditions. That this is the way they described it. We asked, they have a randomized trial to show that that this intervention is effective and in terms of improving health outcomes. Now, we asked our health plans to about whether or not they were supportive of adding this component. Both of them offer comprehensive diabetes management, coaching, nutrition, lifestyle, medication, all the components, while Weight Watchers is adding specifically focusing using their methodology, points and dietary control, but having a specific focus for diabetes. The Kaiser Permanente representatives said that while we have this, there may be some people who are interested in pursuing this, that they were happy that their program had been studied in a scientific manner and validated, and that people having options was a good idea. Moda ended up saying we also have this coordinated, integrated approach to diabetes management, and thought that it may confuse and dilute their efforts. So they were not in favor of offering the Weight Watchers for Diabetes. We don't need to make a decision on that now. CIAO is going to look at it again in June. There is no cost implication for the contract that we're looking at signing with Weight Watchers, which is which would be for the October 1, 2021 through September 30th, 2023. So we're putting on hold for a little while, more discussion for the Weight Watchers for Diabetes. Recommend the addition of digital Weight Watchers Digital 360 into what they're offering, again for a 5% about a 5% increase in the contract for a 2-year period of time. That's it.
Tom, would you like me to read off
Yes,
the contract offer? Okay.
Yeah, please. Thank you.
Sure. So the current program is our population size 111,917 members eligible, and the program offerings are digital plus workshop and Curbo, and that's for 3.1 million in annual value, which is kind of their row of how they assess the value. Our actual OEBB annual program cost this year is 1.35 million. For the proposed program for next year, same population size. In addition to the digital program offering, they would add the digital 360, and WW for diabetes, as well as the digital plus workshop and Kerbo. And that's a 3.7 million value, and the OEB annual program cost would be the same, 1.35 million. For the 21 through 23, so 2-year proposal, same population size, and same programs, same annual program value, but the price would go up 1.42 million, go up to 1.42 million. So 2021 current program and the 2020 to 2021 proposed program is the same price, and adding the WW for diabetes and digital 360.
But for the next year, it represents a $70,000 increase over a 1.35 million current price, which the CL were unanimous in recommending that to the board to accept.
Yep.
And we're discussing it now because this needs to be then woven into because these get included in the rates of our health plans. So I'll start it off by making a motion to accept the rate proposal for a WW with OEB as outlined, the services as outlined by Ali, with the exception that the Weight Watchers for diabetes, which has no cost implication, will be decided at a later time.
This bill, I'll second.
Okay. Is there discussion or questions? Okay. With none being, I don't see any hands raised. We'll move on to a vote then. Bill.
Aye.
Bonnie. Are you still muted?
Yes, please.
Yay or nay?
Yay.
Thank you. Susan M.
Yes.
Susan R.
Aye.
JJ.
Yes.
Reed.
Yes.
Bob.
Yes.
Tom.
Yes.
And Robert.
Yes.
Okay, motion passes. Thank you. Okay, getting back to our order, we'll have our medical dental vision renewal final review by our friends at Towers Watson. Willis Towers Watson.
Hi, everyone. So Jenny Marks here. I think Brad is also on the line. Sure am. Yep, Brad and I all tag team. I do also have Taylor on the line. She's helped put together a lot of the materials, especially the plan design changes and the EAP with Cobra. So she's standing by, ready to answer some, maybe more of the specific questions that might come up. But yeah, we'll go ahead and go through today what our final renewal positions are and what the plan design changes are for, let's just stay here for a minute, and what the plan design change options are for consideration. First, the goal today is to approve the final rate positions and any plan design changes. That's our hope for the end of the program today. So please do ask questions and let us know if you need additional information. I guess before we go ahead and launch into the different renewal positions, I guess I just want to start by saying, providing appreciation to each and every one of the carriers who we worked with. Every single carrier partner really stepped up to work with OEB and provided a really good renewal, creative solutions in some cases, and just really competitive renewal positions. So I'm really thankful for the partnership. I think you'll find that whatever decisions that the board makes, the renewals are a very good and competitive position. So it's all good news from my perspective today. Hopefully you'll agree when we're finished. Okay, let's move forward to our just executive high-level summary. So on this page, what we have are the updated final renewal positions from each of the carriers. And this is inclusive of the taxes and fees. So this is really what entities are going to see in terms of rate changes for each one of the carriers. Now, there are some optional plan design changes being proposed, and so that can change, the final renewal position, but here's where we are to start with. So Kaiser, we're at just a slight negative rate decrease, or we're at a slight rate decrease, which is great news. Moda, their updated final renewal is just under 3%, also below our 3.4% target, so really great news there. On dental, you'll see the Kaiser and Willamette dental renewals are at 0, similar to last month, but there are some benefit enhancements that are included with that, which we'll talk about, that are aimed at increasing preventive dental use. And then on the Delta Dental, they're coming in at just a slight decrease, which is also really great news for members. And we'll talk about the additional plan option for Delta Dental. There is an option for entities to see a rate reduction on Willamette Dental for 1 year, and we'll talk a little bit about that a little bit later. And then on the vision, not a lot of change from last month, but a slight adjustment on Kaiser. They're at just under a 1% decrease. Moda's at the, very close to 0, just a little above, and then VSP remains at the -12%, and that's guaranteed for 4 years. Okay, so that's where we are to start with. So good starting position. Let's go to the next slide. So just as I mentioned, all of the renewals are under 3.4% target. We're going to look at a couple options like the Kaiser new plan, the 1,200 deductible plan. We're going to look at some Moda plan design changes, and that's maybe where we'll spend a fair amount of time in discussion. There's a couple of dental renewals to consider. So I talked through most of that, and then we have the visions. So let's move to the next slide. So in addition to understanding where each one of the renewals is, it's always important for us to talk about where the overall aggregate renewal is, because as we all know, the Oregon legislature sets a target on the overall cost increase of all those things combined, medical, dental, and vision, at no more than 3.4%. So when we take a look at the renewals that we just described 2 slides ago and sort of net out the change in taxes and fees, our starting point right now is at 2.28%. So again, below the cap, all very nice news. Okay, so I think next we're going to talk a little bit, before we dive into a little more detail on each of the renewals, where we're going to give you an update on where we are with the rate stabilization reserve. But before we move on, are there any questions?
This is Tom.
Yes.
I looked at these numbers and I was a little bit schizophrenic. Number one, they are great numbers. And for our entities and our members, seeing numbers that are anywhere from minus a little bit to up to 3% is fabulous. My worry is the worry that I've talked about, forever. With the 3.4% cap, does that cap also though become in a way a minimum? Because when you're good 1 year and you're bad the next year, you don't get to carry over the good to mitigate the bad. So the only thing I'm throwing out is how close do you want the aggregate to be at 3.4 when you don't get credit for landing on 2.28? It's just it's a philosophic conversation, and yet, it's to this year's, good news, does it become something that bites us a year or two or three down the way?
Yeah, I also think that is something to always be aware of. I'll give a couple of comments and then Brad may add some others. I think you're right, and it would be helpful at some point if we could start to talk about a longer term review of that 3.4 rather than year to year. So I'll just put that out there. I don't know that I have the power to make that change, but that would be helpful. But even in this year by year situation,
I know you don't have that power.
I don't. Yeah. Thank you for that. It's helpful. But what's going on with the renewals is that they are very favorable, but we also still, OEB still also has the rate stabilization reserves that are pretty healthy for both Moda and Kaiser, and even Willamette Dental, so on the dental side. So there's still some ability to take this lower renewal and still feel like we're in a comfortable position. I do think we'll talk more about that when we get into the individual renewals. Yeah. I don't know if you have anything else, Brad, to add to that.
No, I think it's just important to remember, and this is actually a great segue, Tom, into talking about the RSR and the tools that we have available to help mitigate some of that year-to-year fluctuation. Right now, I think we're in a pretty good place to mitigate, the small variations up and down that we would expect in a health plan rating. And this year we're in a great position as a low year. So that's a very, very good position to be in, and still retaining some ability and flexibility through the RSR balances going forward.
And Jeff, this is Ollie. I would just also mention that we did talk to the Ways and Means Committee in our presentation regarding last year's low renewal and how resetting this baseline at a lower level than 3.4% has potentially a big impact on the next year. And I really do think that these legislators are understanding this 3.4% test a lot better than they used to. And Rep. Nose actually requested a follow-up meeting, and we talked about a rolling 12-month or 24-month average and a better way of doing this annual test. So that's all really good.
Yeah, thank you, Ollie. Anybody else have any questions before we move to the next section?
This is Bill from county policy point of view. The real policy should be around where we should set the RSR fund at, not really getting close to the min that the legislators set. We need to be comfortable with the RSR and what might happen in the following 3-year projection, and that's what we're targeting. Right, where it falls in the 3.4 is just where it falls.
Okay, why don't we go through this next section and then bring that up again, Bill, if you're okay with that.
Oh yeah, I was just trying to intro.
Oh, thank you.
And a great job. All right, so we can move to slide 8 really quick. And this just will set a foundational background a little bit and provides kind of a starting point for our RSR discussion. Recall that, when the 200% Medicare cap was introduced, we did have a pretty significant one-time savings. And rather than take that all as a kind of anomalous bump down, we did decide to commit some of those funds to a rate stabilization reserve. And since then, we have had a little bit of additions to that. We've also had a little bit of use to that from the various plans. And currently, with no other action, we would expect the balances as of the end of this plan year, September 30th, 2021, to be just a little over 26 million for Moda and just a little over 15 million for Kaiser, from a balance perspective. Kind of if there's no questions to that, we can kind of move into slide 9, which talks about a little bit of the bumps that we had, in implementation of that hospital cap rule. Recall that did go into effect 10/1 of 2019. And, after that, we did find a few issues in there that required the adoption of clarified rules. And one of those issues was that the rules as they were originally passed allowed hospitals to bill up to 200% of Medicare instead of billing at the lesser of billed charges or 200% of Medicare. And this caused a number of issues, caused some payments to be larger than they otherwise would have been. And in fact, we do have an example of this sort of in the table on the middle. So we'll kind of walk through that table, and we're going to highlight 2 areas that really came out from kind of an OEB plan paid perspective, but also some areas that had very real impacts from a member perspective. And so as they were adopted, the first column in there shows kind of an example of what happened for a sample surgical procedure. So this surgery normally would have billed out at $14,400, which was below 200% of Medicare. I believe the 200% of Medicare amount was about $20,000. And so under the rules as originally passed, Moda was not able to cap at the billed charge and was required to pay out adjudicate at the $20,000, 200% of Medicare level. And so in this case, that $20,000 split out into about $15,700 for the plan paid and about $4,300 for the member paid. Under the clarified rules, which would cap that at the billed charge rather than at the 200% of Medicare charge, that claim would have adjudicated at $14,400, which would have meant the plan paid out at $11,200, and the member cost share would have been only $3,200. So, kind of looking at those 2 impacts separately, we'll first talk a little bit about the plan paid impact, and we can see that there was, a very solid, $4,500 or so of additional plan paid charges. During the last renewal cycle, Moda and the board were aware of this issue, and we did, approve a kind of a contingent arrangement that said, hey, if these clarified rules were not adopted by 10/1/2020, Moda could recover the amount of these, excess claim charges. So Moda agreed not to build in these excess claim charges to their 2020-2021 renewal, but if they, with the stipulation that if those rules were not adopted by the start of the plan year, they would be able to recover these excess claims. And so because the clarified rules were not adopted until December 2020, there is a recovery amount that we would expect to pay for from the RSR of about $1.26 million. So kind of that's from the plan perspective. From the member perspective, I know Moda and staff have been talking about this impact to the members, and there's been discussion that they would like to indemnify members that were impacted by the lack of the delay of the clarified rules, and kind of make those members whole for the excess amount that they paid, over and above what should have been paid, per the example above. And so if we go back through and Moda has taken the time to go back through and really look at all these pieces, and it looks like the amount of that is approximately $500,000, maybe just a little bit more than that. And so, we would like to propose using those RSR funds to reimburse member cost share for those excess payments.
Ali, could you add the staff position on that?
Yeah, you bet. So really, if the board remembers back about when the pandemic really started and things shut down, probably last March, the governor asked that we put our rules on hold that we were implementing the lesser of rules, and didn't lift that until December. So, a good 8 to 9 months later. And I've talked to several members that were impacted, and, it's really nothing that they did. They were just kind of a victim of this situation, and really shouldn't be on the hook for these extra charges because of the situation. And so through no fault of their own. So we want to make them whole. As you see in the example there in the table, we're working with Kaiser on the same issue. They're just a handful of members, I think about 16, that are impacted by this, and we'll determine next steps with them. But we would like to ask for the ability to make members whole on the Kaiser side as well.
Discussion from the board.
Agree with staff.
Seems like a good use of the RSR.
Yeah, agreed.
Okay. So Ollie, I think we need a vote on this.
Yes, sir.
Okay. Bill,
Aye.
Bonnie,
Aye.
Susan M,
Aye.
Susan R,
Aye.
JJ,
Yes.
Reed,
Yes.
Bob,
Yes.
Tom,
Yes.
Robert.
Yes.
Okay, motion passes. Okay, please continue.
Okay, so we can move on to the next slide, slide 10. And slide 10 shows kind of a illustration of, how these projected ending balances would change for the, not only the Moda, distribution of the RSR for the plan paid expenses from October through December, but also for the member indemnification. There we can see on the Moda side, we would go from that 26.2 million. We would subtract about 1.3 million for the delay of the clarified rules, another 500,000 for funding that member cost share reimbursement, and that would take us to right about 24.4 million for the end of the 2021 plan year. On the Kaiser side, we started with a $15.4 million balance. I believe in the March meeting, the board approved use of just about $800,000 of that RSR to continue funding for the wellness-based mini grants and flu shot clinics. And that takes the expected Kaiser RSR balance down to 14.6 million. So any questions on those?
So that's assuming that the rate proposal in about 4 pages ago is not adding or taking away from the RSR, right?
That's correct. Okay. Any questions on that? And we will talk about, there is a proposal on the table to use a little bit more of those RSR funds in collaboration that we'll discuss during the Moda Renewal section. So we can move to slide 11, and we thought it would be worthwhile taking just a few moments to introduce the idea of thinking about how these RSR balances should be used. We kind of got together, did some brainstorming, and came up with some thoughts on recommended uses that I think will tie back to some of our earlier discussion, as well as a couple of areas to highlight that we think are not appropriate uses or not good to do on a general basis. So the first and foremost, we do think that managing to this annual 3.4% target and in using that RSR similarly to how it's been used in the past is entirely appropriate. And this gets back to the discussion of, hey, sometimes we may have a renewal that comes in at 2%, and sometimes we may have a renewal that comes in at 4%. We know that plan costs and utilization are not static. They are going to have an underlying variance that's going to change from year to year. And we do think that use of those funds, those RSR funds, to help bring those in line a little bit year over year is an entirely appropriate use of those RSR funds. We also feel that investment in care management programs that will demonstrate a long-term ROI, such as the Centers of Excellence, would be a good use of these funds, as well as pilot programs that could be reviewed and evaluated prior to adoption for the whole OEB population. In addition, as we've seen for the Kaiser kind of wellness space grants, we do think that value-added benefits such as the wellness benefits are a good use of those funds as well. On the other hand, from a not recommended standpoint, we do not recommend significant buy downs of those rates. And that is because if we know that by artificially lowering these rates to a big degree, say maybe 2 to 3, 4% or something like that, we would have a massive catch up the following year that would be very difficult to bring back under that 3.4%. So carefully managing that so that those buy downs in our years were a little bit high don't become a double-edged sword the next year. In addition, we don't recommend funding benefit enhancements with the RSR, as if we fund them 1 year, that just means that we have a magnified rate impact the following year for those. Any questions on that? I think we'll probably get into further discussion and a map out of these a bit later on in the year as well.
Brad, just for clarification, when we originally voted to establish RSRs, we talked about kind of spreading our savings out over 3 years.
Oop, I think you just went on mute, Jeff.
Yeah.
Oh, there you go.
So it seems like we've morphed into an even more conservative approach, where we're kind of trickling the use of it, conservative. So did you want to just affirm or comment on that, please?
Yeah, I think I would say there's a little bit of a refinement in there, and I think it's a sensitivity to be careful about how much of that is used to control the the target. I think we have to just be very careful if we have a 6% renewal 1 year, buying it down by 2.6% while it gets us to the target. We have an immediate 2.6 hurdle to follow the following year, and that's okay if we have a really big reduction. But if we do come in around 3%, say for example, that following year, we would be facing a hurdle of over 5% to get below that 3.4% target. Yeah. So I think just a careful consideration of that on a year-over-year basis, from a buy down perspective. And I think it also highlights the need to be very thoughtful and very deliberate in maybe taking an approach on how to use those RSR funds.
So I would just reiterate, you're putting a premium on sustainability.
Mm-hmm. Correct. Yeah, that's a great way to put it.
Thank you.
Mm-hmm.
Any other questions?
This bill again, we can come up with like a policy formula on what we're targeting, the following year's RSR amount. And this is not real numbers, but just saying, like, if the following year was a 5.4% calculated up, we have that plus the wellness funds, a couple million for wellness funds, plus the account balance going up and down as we're spending and doing through the year, and make a formula that says, based on current numbers, and you don't put a value there because the health insurance costs are going to change every year, but you have a percentage based on where you want to have a safety fund in there in case, for example, in case next year is 5.4%, you need to buy it down to 3.4%. That's the minimum for that part. Then plus those other parts, and you come up with a formula, and each year you say this is our targeted RSR.
So Bill, are you suggesting that we look at a maintained RSR? Am I misunderstanding you?
That would be the case, and like that's, I mean, for those of us who run school district budgets, you can't roll a zero fund ending balance, right? You have a targeted ending fund balance that controls several factors in what you might encounter in the following year.
Yeah, and Bill, I think that is those are very good comments and very good points, and that's kind of why I think it's going to be important in the following months, or I think it would be a good idea in the following months to really discuss that and explore that concept of a more deliberate strategy, so that as we move forward, we can have a little bit better idea of what we want to accomplish and how we want to get there.
Okay. Would it, if we scheduled discussion for that at our June meeting, would that be acceptable to you?
Oh yeah, whenever, just it takes that guesswork out of, hey, we're under 3.4, but we should save some of that, and there's no like, oh, I feel this, you feel that. Right now we have a methodology around that explains it to people, so they can understand, and we don't look biased.
I think June's a good time to do that because we are past our decisions and we're not yet ramping up for the next year. So that's probably the most neutral part of the entire year. So Ali, let's put that down on our agenda for June.
Yeah, we actually have discussed reserve policy at the June meeting. So we'll just add RSR into that.
Good, thank you.
I did not look ahead to know that. I was unaware. That was just luck.
There's actually there's an auditor recommendation, so you're on the ball. Actually, you're right on the ball.
Clairvoyant. Okay. Consultants, please continue.
Okay, I think that Jenny, do you want to chat about the Kaiser and Moda renewals?
Yeah, can you hear me?
Yes, can now. Mm-hmm.
Okay. I just super fun, just lost internet connection in the middle of the whole thing. So I'll just join you by phone and I'll let you know what slide I'm on, and then maybe somebody just let me know if there's a question, because it's kind of hard to tell on the phone. But so
Jenny, I'll moderate questions and be happy to step in if something happens again.
Okay, well, I think we both know the info pretty well, so we could probably each go for each other. But I'll go through the Kaiser renewal. So on slide 13, as I mentioned early on, the Kaiser renewal is quite good. We did work with Kaiser to refine the position, and they agreed to refine their position and come into just a hair under 1%, above a 1% decrease. So we do feel like it's sustainable, and Kaiser agreed, and I do appreciate Kaiser's partnership on that as well. So good news for members. If you remember at the last board meeting, there was general agreement to add the $1,200 deductible plan. And so we've got sort of illustrative rates here on a composite basis for each of the new plans. I will say that these rates are still illustrative because we need to confirm them with the carriers. We need to add in the OEBB admin fee, and then I think the decision about the Weight Watchers may ultimately slightly refine these final positions as well. But other than that, there weren't any other benefit changes to be decided upon at this renewal. Okay, let's go ahead and move to slide 14. So the Wellness and Innovation Fund, I know Brad talked a little bit about that, and we talked about it at last month. And again, there was general agreement by the board to continue those wellness-based mini grants and the on-site flu shot programs for an additional 3 years. And that funding would come from the Kaiser Rate Stabilization Fund.
So that really brings us to slide 15, and hopefully a decision point. We are recommending accepting Kaiser's renewal proposal, the addition of the new plan, and the continuation of the wellness programs is proposed. Are there any questions?
Sorry, Bill again. There's a new plan for Kaiser, and I know the original assumption was no migration, but there'll be some migration into that plan. Is that minimal impact if there is?
Yes, we didn't really want to model a lot of enrollment in the new plan because it's really tough to predict. And, you know, when the plan 3 for Kaiser first rolled out, there really wasn't a lot of enrollment in the first year. It's grown over the last few years, but just to be conservative again, to our weighted average target, we didn't want to overly assume too much enrollment in the new plan.
Thanks.
Okay, any other questions? If not, like a motion to accept the Kaiser renewal.
This is Bill. I'll make a motion that we accept the Kaiser renewal staff's recommendation as presented.
This is Sue Ricky Smith. I second.
Okay. So JJ, how do you vote?
Yes.
Reed,
Yes.
Bob,
Yes.
Tom,
Yes.
Robert,
Yes.
Bill,
Yes.
Bonnie,
Yes.
Susan, Miller,
Yes.
and Susan R.
Yes.
Okay, that carries.
Okay, good. So we can move on then to the Moda renewal. And I'm on slide 17 of the WTW presentation. So the Moda renewal, again, just some refinement over the previous month's rate calculation. And even this, I would say the 2.94% includes some really nice concessions and partnership with Moda. So we really appreciate working with them and through the process. And the 2.94% is definitely sustainable. I know we're going to talk about another option here to lower it even further, but you know, if the board wants to accept the 2.94, that's also a sustainable renewal position, and it's a great one for members as well. However, we did understand that you know, OEB really wanted to get a more competitive proposal if possible. And so we proposed and worked with Moda to come up with an idea to further reduce the renewal using some of the rate stabilization reserve funds. And so, and then by doing that, Moda was feeling more comfortable about being a bit even dialing in some of the additional factors in the renewal. And so they said, you know, they agreed to go ahead and do that additional half-point refinement on the renewal. So overall, the 2.94% renewal would come down to 1.94% if approved. So we I don't know, Brad, if you want to add some commentary, but we do feel like the 1.94% is also sustainable. It's a little bit more aggressive. It still leaves a fair amount of money in the rate stabilization fund to be used in the future. And the Moda program is currently running at a slight surplus on the medical plan. So that does allow Moda to be a bit more flexible when it comes to having these discussions.
No, Jenny, I think that was well said.
Okay. And then I think Moda was on the line. I just wanted to make sure you didn't have anything else, Erica, to add to that.
Sorry, hi, thank you. Yes, Jenny, I think you did a great job explaining that. And as you described, the minimum premium arrangement is currently in a slight positive surplus, which does allow us to be able to come off of that rate a little bit. And so we did work together to come up with a creative solution.
Tom, you have a question.
It's more of a comment. I am particularly when we're under the 3.4, I am anxious to be spending the RSR. I think the RSR needs to be saved for that rainy day when we're heads up against the 3.4.
Brad, would you kind of elaborate on minimum premium surplus versus RSR and kind of how they may complement each other?
Yeah, happy to do that. I think that, right now the plan over the last, well, I'd have to be really exact, but probably over the last 12 months or 13 months has performed pretty favorably, going from a deficit position to a surplus position. And I think the intention of that surplus position, as Erica kind of stated, it really allows Moda to, relax a little bit on an otherwise, tight underwriting guidelines. And so, there's certainly always an area of ranges for assumptions and for underwriting results. And I think by having that extra surplus in there, the intention is for that surplus as it's built up, the intention is for it to eventually be used and brought down with the goal of the ultimate end goal would be to have it be zero at some point. In an ideal world, it would always be zero, right? So we know that as it starts to increase, there is some benefit to some level of spend down, and I think the RSR is in that position as well. We still have a pretty sizable RSR balance in there, and I think it felt like a very good use of those funds to partner with Moda on that and to get that extra benefit in this kind of a lean time for the entities. And I know I see a hand up, so I don't want to a couple hands up, so I don't want to take away time from other members.
Yeah. I think Reed was next.
Yeah, thank you. I had a question about the some of the elements that are included in this final renewal proposal. The gender reassignment facial surgery coverage, which I totally support. I'm just wondering if there's a sense for how many people that might be a year.
I'll try to take that one. So honestly, that one's a difficult one to tell because it hasn't been covered in the past, right? So we can use some assumptions, and it was I think fewer than 35 people. Again, it's really tough to tell. So around 35 people we think has gone through a gender reassignment and maybe looking for that facial confirming surgery, but they're not always going to be approved. It's up to the physician to decide, if that really helps the member in their journey. We haven't quite got to that piece yet, but I would say, and just so you know that facial confirming surgery isn't yet included in this 1.94% discussion.
Thank you.
Right. Mm-hmm. Yep.
And Tom, did you have a follow-up comment?
Yeah. If we weren't living in the middle of a global pandemic, I would not have the same anxiety as I have for going low. I still worry that I think that there's a good chance that once people go back to the usual order, life will become there'll be pressures pushing costs up. So that also plays into my my concern. I agree that as I started, these rates are fabulous, and your proposal to lower Moda's again even more is for the short term is great. I'm anxious about what happens over the next 3 years. That's all what's behind it. I am the work that the consultants and the plans have done to give us this rate, and even this additional proposal is wonderful. I'm just expressing anxiety.
Okay. Consultants, please continue.
Okay. So on slide 18, again, this was just a visual description of how the rates would change if the 1.94% renewal is approved, but we still do have a couple of plan design changes to talk about. These are holdovers from what we talked about last month, and so I'll go through and explain them again. So let's move to slide 19. So the three plan design changes that the board asked us to come back and discuss again are coverage of the facial confirming surgery for those who are transitioning genders. And that, so Moda has refined the rate impact to a 0.12%. So what that means is regardless of whether you choose the 2.94% renewal or the 1.94% renewal, this benefit is going to, bump that up just a bit by 0.12%. And I'll talk about that on the next slide. The other two plan design changes have to do with increasing either the maximum cost share or the maximum out of pocket for the plans, just sort of as an effort to keep up, if you will, with inflation. And it's been similar to what the board has done in past years. So we'll talk about that in more detail in the following slides. On slide 20, we did talk a little bit about the gender confirming facial surgery. The reason that Moda has refined the rate impact has a lot to do with their plans to establish a center of excellence approach for having the surgery done. So they want to work with one or two facilities, I think, that will specialize in the surgery and help make sure that the procedure is done at the right cost and the right quality. But just to go back to why this benefit change is being proposed, I mean, it was originally reviewed in the CIAO group. Moda has proposed the change so that because it aligns with a lot of the recognized professional associations who kind of really delve into this and take a look at what's the right type of coverage. So it aligns with that. It does align with the CCO plan coverage guidelines, and it also aligns with what Moda is doing across their commercial book of business. Kaiser is also providing the coverage for their book of business and for OEB members. And we did identify during our review that there is potentially a legal risk associated with not covering it. And that said, there's currently a lawsuit not related to Moda or Kaiser, but there's currently a lawsuit happening with another Oregon insurer about their decision not to cover that. So again, addresses a variety of different reasons. Are there any questions about this? Okay. Maybe I'll just go ahead and move on to the cost sharing one. Okay. So there's all of these slides are the same as what we discussed last time, but the main idea is that I'm on slide 21, is that the couple of different departments within the federal government establish what is the maximum amount a member should have to pay in medical or pharmacy costs in a year. And it's interestingly different for HSA style plans versus non-HSA style plans. Even though they're different, both of them still often need to apply. So it's good to kind of take a look at this. If you move to slide 22, so on Moda plans 1 through 5, those are those non-HSA plan designs, and those plans have what's called a max cost share. And the max cost share is a little different from the medical out-of-pocket max. So if you see there in that purple circled area, the medical out-of-pocket max establishes the most a member would pay just for their medical costs, so hospitalization, office visits, etc. And because the law establishes an overall cost-sharing limit for both medical and pharmacy, plans either need to increase their maximum out-of-pocket to account for the pharmacy costs, or they need to set a separate pharmacy maximum out-of-pocket cost, or they need to do what Moda's done, which is establish a larger maximum cost share, which includes both the medical costs and any pharmacy costs. So that's what we're talking about, indexing up each year. So most years the board has approved the indexing up of this maximum out-of-pocket, the maximum cost share limit. So if you move to the next slide, slide 23, this has to do with the two HSA plans. So HSA plans have a different set of rules, and the maximum out-of-pocket on those two plans, interestingly, does include pharmacy costs. So it includes medical and pharmacy costs. They're higher generally, for the most part, they are higher than the plans 1 through 5 medical maximum out-of-pockets. But if you're going to sort of increase the max cost share on plans 1 through 5, it sort of makes sense to also do it on plans 6 and 7, just again to maintain the right pricing and relativities between the plans. So that's why we're bringing it up at this point. It's a good thing to do if there isn't an appetite to accept that this year. It's definitely an idea that we'll come back and talk with the board about next year as well.
Well, let's pause a little bit and talk about maintaining relativity, incremental change as opposed to making larger changes. Brad, do you have a comment on that?
Yeah, I think, on each year, our cost share can be eroded a little bit as as those deductibles and out-of-pocket maximums lose their value with trend. This year was, of course, not an example of that, as we had the pandemic and cost decreases. But in general, this really what it does is it protects the value of the co-insurance as a percentage of cost and helps to adjust the plans on an incremental basis relative to general inflation. So, I think in general, it's either a question of, do you want to make small changes as you go along, or do you want to make, big changes every, 3 years or so? And I think historically the board has elected to, make this incremental change almost every year.
JJ.
I just had a couple of thoughts, and it's just one board member's thought, so take them for what they're worth, which is 1/10 of our decision. The conforming surgery, I think the risk reward is worth doing it. I think that the litigation risk is legitimate and therefore worthy of consideration. Also, conformity between Kaiser and Moda, I think there's value in that. One thought on the inflationary increase is, in our annual assessment on the value of our plan versus the value of similar plans in other public sector entities, our plans tend to be a little less rich. And because of that, I'm actually in favor of not giving the incremental inflationary increase, because it puts us a little closer to what is typical in public sector plans.
Okay.
That's all I got.
Robert.
Yeah, on the inflationary piece, another way to look at it, just another angle, is on pages 42 and 43. Those pages identify how many people have reached those maximums, and it's about 1,000 people. So, in effect, I think what are the other angle of this decision is it's taking a 0.5% decrease for everyone at the expense of 1,000 people, or holding firm for the 1,000 people and not giving the decrease benefit to the full body. I'm not making a judgment on that. I'm just, that's how just another way I've been looking at it.
Okay.
One other thing on the rate stabilization consideration, as a general rule, I try to avoid advocating for using RSR funds strictly for rate decrease. This one's, I think, a little different in that it is partial rate decrease, and then Moda is matching some of that. So you're getting a better bang for your buck, I guess. So I think within this year, I would support that decision as well.
And, you know, following up with JJ, I agree with that as well. So I agree with the gender confirming facial surgery. I think that's the right move. I'm okay with the RSR adjustment. I'm totally torn on, you know, whether to increase the maxes.
This is Taylor. I just wanted to jump in and make a quick comment, because I know the way the tables are oriented in the back might be a little bit confusing. But the number of members who have actually met that maximum cost share for plans 1 through 5 is a lot less. And then also for it's closer to about 225 members for plans 1 through 5. And then for the plan 6 and 7, the HSA plans, it's closer to about 200 on plan 6, and then about 50 on plan 7.
Okay, thanks, Taylor.
I added in Kaiser as well, so
Yep.
that's why I came up to 1,000.
Totally. Yeah.
So Jenny, on the next page, don't we have our voting decisions?
Yeah, so if we go to slide 24, these are the 4 scenarios that we put forth for consideration today. Just to orient you to the slide, we've got the different scenarios labeled A, B, C, and D. And so in the table is the change to the Moda plan. So, you know, for example, scenario A is the 2.94% base renewal. And just so that you understand, off to the right is our march towards march under the 3.4% target. So it kind of shows you for each one of those scenarios how that particular scenario changes the overall legislative target amount.
Right. So just to reconfirm, the table has the Moda renewal, and the little speedometer is our composite renewal before taxes and fees. That's our legislative target for all of the plans combined.
With this is JJ. I move we accept option C.
Okay. Is there a second?
This bill, I'll second that.
Okay. We'll start with Reed.
What? Can you come back to me?
Bob.
Yes.
Aye. Tom?
I have problems with the motion in that it doesn't allow us to, there's parts of it that I'm in favor of, and there's parts of it that I'm not in favor of. So it's,
well, if we don't
I
accept
wonder,
it, if we don't accept it as is, then we'll back up.
Yeah, I think the procedure here, each of the issues should be voted individually. We should decide whether or not we're going to use the RSR. We should decide whether or not we're going to do gender confirming surgery. We should decide what we're going to do on out-of-pocket costs. That's my proposal. I'm voting against C.
Does anybody else have a comment on their preferred method?
But
I'm willing to back
sadly,
up.
you're kind of in the middle of a vote right now, so
Yep.
you kind of have to.
I'm
I mean,
stuck.
if we're following the rules, we need to finish the vote because you
Okay.
already started the vote.
So we got a nay from Tom.
Right.
Okay, Robert.
Still conferring.
Is he laying on the floor?
Dang it, sorry. So I am going to say no for the time being, just so we can back up. I'm not necessarily opposed to Plan C.
This is JJ. I'm willing to rescind my motion, and with the caveat that we could take each issue separately.
Can I be a nerd? JJ can't rescind his motion, but somebody else can.
Okay. Who's got the book on proper procedure?
That's Parley Pro, right?
Or we could all just vote no and then move on and try again.
That would be an
I think
agreement.
that's proper procedure.
Yeah, that would be the best procedure forward.
Okay, so I'll race down this. So Robert's a no. Bill, you're.
I'll go with no to
Bonnie.
To go with the flow.
Bonnie.
No. No.
Susan M.
I'll go with no under the circumstances.
Okay, Susan R.
No.
JJ.
No.
Reed.
No.
And Bob, did you want to change your vote?
I'll join the crowd. No.
Okay, we got a do-over here. All right. I'll entertain a new motion.
I'm going to assume that we can combine the first two, which is I'll make a motion that we accept the baseline Moda proposal with the adjusted Moda renewal and the reserve funds.
Okay.
That's basically just adding in the reserve funds, the item one, right?
This is JJ second.
Okay. So essentially that's B, right?
Yes, right.
Okay. So it's moved and seconded. Robert.
Aye.
Bill.
Aye.
Bonnie.
Now she's on the floor.
Bonnie's having some problems with her internet.
Can we see? Oh, we can't see her, can we? Come back to her.
Aye.
Susan Miller.
I'm back on there. Aye.
Okay. Susan Miller.
Thank you.
Aye.
Susan R.
Aye.
JJ.
Yes.
Reed.
Yes.
Bob.
Yes.
Tom.
No.
Okay. All right. So that motion passes. Is there a motion to accept gender confirming surgery?
That's
So
Bill again.
moved.
So
This
okay. I was going to actually state it, but JJ just said so moved. So
So we have a motion
and Robert seconded. Right.
and seconded. Okay. Starting at the bottom, Tom,
Yes.
Bob,
Yes.
Reed,
Yes.
JJ,
Yes.
Susan R,
Yes.
Susan M,
Yes.
Bonnie, we'll come back to her. Bill,
Yes.
Robert,
aye.
and is Bonnie on yet?
Yes. And I vote yes.
Thank you. And then hang on for just a second. I just have to print another voting sheet. Is there a motion to change the maximum amount of pockets?
So moved.
Is there a second? Looks like I'm sorry, I couldn't hear very well. So,
This is Robert. I'll support Tom's motion.
okay. So maximum amount of pockets. So starting at the top, Robert.
I'll go with yes.
Bill.
Nay.
Bonnie.
Nay.
Okay, Susan Miller.
Nay.
Susan R.
Nay.
JJ.
No.
Reed.
I'm gonna vote no.
Okay, Bob.
No.
And Tom.
Yes.
Okay, the motion does not carry. All right, we have those changes.
I just wanted to say thanks to the board for putting up with that. It was it worked that we dealt with each of those individually.
I think it's good that we do a good job of hearing everyone's voices.
Yes. Okay, how are we? We're doing pretty well on time, I think.
Yeah, I think so. Should we move to dental?
Yep.
Okay. Actually, I think Brad, are you gonna take us through the dental?
Yeah. I can walk us through dental here. You know, where I'm on page 26 of the Willis Towers Watson presentation, the renewal presentation, and we've got a kind of an overview of the dental renewals, followed by a few comments. So we'll kind of walk through those. Currently for dental, we have a delta coming in at negative 0.9. This does reflect Delta Dental's decision or agreement to remove margin, reflecting the surplus position that they have in the plan right now. So, you know, we're seeing some positive or favorable willingness to move in a rate perspective due to that surplus. So very positive thing. And that does also include the addition of that new Delta dental EPO plan in there. So Kaiser, per their book of business, is coming in at 0%, but that does include a reduced copay for preventive office visits. They did change that from $20 down to 0%, and that's been estimated to be worth about 2% from a concession perspective from Kaiser. Willamette is coming in at 0% as a baseline renewal. However, there is a fairly unique consideration for the Willamette renewal. Given the favorability from the pandemic, the RSR for Willamette has reached its contractual cap and can no longer be increased. And so because of this, we do recommend that half of the current RSR amount, we're not talking very large dollars here, half of that be used to buy down the 2021-22 renewal, which would take it from about 0% down to you know, just a hair below 4%. We feel that this is a reasonable use of those RSR funds and will allow for further accruement, you know, if available in the next plan, in the current plan year and in ongoing into the next plan year. And, you know, if that bounce back does happen and we go back from that -4 to a 0 or a small increase next year, probably won't have a large impact on our composite position relative to our 3.4. Any questions or comments, particularly on the Willamette use of that RSR funds?
Brad, I have a question on the Kaiser. The reduced co-payment, does the 2% incorporate just a one-time 1 year adjustment, or is this going forward after year one?
I believe that is
makes
just
sense?
I believe that is just a current year. I believe that's just a current year concession. Although, we do feel that it's, could be relatively sustainable. I do want to emphasize that Kaiser did not go through they didn't go through a traditional renewal process this year for the dental benefits. So, very difficult to tell what the plan position really is, as it's coming out of the pandemic.
Thanks.
I see another hand up.
Yeah, this is Reed. Can you tell us a little bit more about why you're recommending using half of the RSR as opposed to using just, 25%?
Yeah, absolutely. So, unlike the RSR that was established for the Moda and the Kaiser plans, this RSR has been in existence for a while and has a cap limit that's contractually based at a fairly small amount. And, it's our feeling that over the course of the year, enough surplus may continue to develop, or enough RSR may continue to develop that we feel we want to use up enough and then to leave room for potential growth in the future.
That makes a lot more sense. And are you making that prediction based on post-pandemic utilization rates?
Yeah, general market, from a general market perspective, what we've seen, and from general market, current dental utilization levels that we've seen so far. Did that answer your question, Reed?
Yes, thank you.
Okay.
Next page.
All right. So in the next page here, just we won't walk through all this by any means, but this is there we go. This is just a quick description or a quick outline of the plan designs for the OEBB plans, and including the new Moda EPO plan. It allows you to kind of check out where it positions. It's a little bit of a richer annual maximum or benefit maximum relative to the rest of the Moda plans, and also gives you an idea of, even though it's a little richer benefit, it is falling in just a hair below Plan 5 from a current renewal or rate perspective. All right, I think we can move on to the next slide, 28 here. And this is, kind of our recommendation slide. The staff and the OEBB consultants are recommending acceptance of that Moda dental renewal with the addition of the new EPO plan. I believe that was discussed in the March meeting as well. Acceptance of that Kaiser dental renewal and the reduced copay for preventive office visits, and acceptance of that Willamette dental renewal with the application of the RSR funds to reduce rates. And I did not mention, I apologize for that oversight, that does include a one-time waived office visit copay for members who have not seen a dentist. And the genesis of that is really to try and improve, utilization of preventive services. So kind of trying to either break down a financial barrier or just provide a little bit of incentive for members who are not currently seeing a dentist.
Okay, I'll take a motion for each of these one by one.
You want to go one at a time instead of just staff recommendation? All right.
Well, I'd be willing to take all of them together.
But maybe maybe they would be
I,
okay.
I'm not sure if there's, I haven't heard anybody saying anything negative about any of them. So I think it may work that we can do it all in one.
This is JJ. I move that we accept all of the recommendations of our consultants for dental renewals.
This is
This
Sue.
bill, I'll
Reese.
second.
I second.
Sue.
Thank you, Sue. All right. Susan Miller.
Aye.
Susan Ricky Smith.
Aye.
JJ.
Yes.
Reed.
Aye.
Bob.
Yes.
Tom.
Yes.
Robert.
Yes.
Bill.
Yes.
Bonnie.
Yes.
Okay, motion passes. We're back on the unanimity train. Thank you.
All right, and back on to vision. Jenny, I think you were going to walk through the vision renewals.
Yeah. Well, I'm gonna. Can you guys hear me?
Yes.
Okay. Well, Brad, you may have to help me with this because now what happened is my computer completely just died. So I don't know what you're looking at, but I do remember.
How about I just walk through it if you're okay with that?
Okay.
All right. You gotta love the technology these days. It's a beautiful thing. So this will not take very long. We do have kind of a renewal summary on slide 30. And we talked a little bit about this early on at the start of the meeting. We have Kaiser coming in at a negative 0.93. We have Moda coming in at a just a hair over zero at plus 0.3. And then we have VSP coming in at negative 12. All of these are on an after taxes and fees basis. VSP is, in addition to their decreases, also proposed a plan enhancement, and that is including coverage for vision therapy, and that can be used to treat a number of things. The lazy eye, I actually don't know what turned eye is, but eye focusing and ocular motor functions. Various therapy items that they're willing to include for no additional premium amounts in there, in addition to that reduction. And so, just to give you a feel for where the plans would land, on a composite basis, we have the ranging from Kaiser at $19. We have the kind of premium Moda Opal plan at $54, followed by the Pearl at $44, Quartz at $31, VSP Choice is at $19, and the Plus is at $39. And so I think that takes us to slide 31 for our recommendation, and we are, just recommending acceptance of both the Kaiser and the Moda and the VSP renewals, the VSP including that adoption of that included vision therapy benefit.
This bill, I'll move that we accept staff's recommendations for the vision plan renewals from Kaiser, Moda, and VSP.
This is Reed. I second.
Okay. We'll start with you, Reed.
Aye.
Bob.
Yes.
Tom.
Yes.
JJ.
Yes.
Susan Reike.
Yes.
Susan Miller.
Yes.
Bonnie.
Yes.
Bill.
Yes.
Robert.
Yes.
Good, thank you. Motion passes.
Okay, I think that probably takes us to the EAP, and so I'll start and just give you a background, and Taylor, maybe you can provide specifics on what's on the page. But just what we talked about at last month's meeting was that, in general, we've been seeing some decline in utilization of the EAP with RBH. I will say that is pretty common with what we're seeing across clients in general during the pandemic. And it could be that members just didn't remember to use the EAP, or it could be that they were using some of the telehealth options available through the medical plan. regardless, there was a reduction. So the board or the general request was to go back and talk to RBH about a refined EAP renewal for just 1 year, and then we would look at utilization and consider potential changes or differences in some following years. And so in general, what RBH again was very partner oriented and said, you know, we know that the goal is that we want to provide as many visits as possible or as reasonable to members through the EAP, and we definitely want to work on promoting the EAP a little bit more. So they proposed for this next year to increase the visit model to 6 visits for everyone. So for most entities, they'll be able to have more visits available. And then the fee will be 80 cents per employee per month. And so for sub-entities, that's going to be a lower fee. And then for those who are on the 3-visit model, it would be a 10-cent increase to the fee. But again, it's more visits. So it's perhaps a better value if folks are using it. So that's where we started with the renewal proposal. You know, that certainly can be approved, or we can have discussion about whether that's appropriate. We did talk to OEB about, well, what about those entities who would see a 10-cent per employee per month increase? And OEB, you know, if OEB wants to just sort of subsidize that amount to allow the additional visit limit to be available, I think Ali agreed that could be done through the general OEB reserves, and it would be about, now I'm going by memory, but I think it's like 75,000. You can keep me honest, Taylor.
Yep.
74. You're really close to
Okay. Okay, so that is the highlight, and I think I covered probably most of what was on that slide, but I don't know, Taylor, if there's anything else to cover.
You did a great job. The only thing left on there is the on-site trainings and resilience coaching and training that Reliant has provided in the past. They're going to continue to offer that at the same rates that they've been offered previously. So those stay the same.
Yep, and they also included the digital coaching as well, which was previously a buy-up option last month, but they've included that in the base 6 model visit for everyone.
This is Tom. Nice work with the negotiation with RBH, and thanks RBH to be so responsive. This is great.
Good. Any other questions?
I think it's a slippery slope for OEB to subsidize programs. That's just a general comment.
You know, Tom, that's a good question. Jenny, was it the intention to just do that for the 1 year as sort of a gap between having this particular program and the evaluation in the upcoming year to, you know, either make this a permanent solution or find a permanent solution?
Yeah, it's just meant as the 1 year. So I think that is a valid concern, right, to start subsidizing programs. The 90-cent rate is very competitive. So, you know, we did a lot of work. Taylor did a lot of work reviewing the rates and what others offer for something similar, and it's very competitive. So it's a really good value, and I would hope that OEB entities would find value in the additional 10 cents.
I'm glad to see the communication plan that's embedded in here, because I think that the problem is if nobody knows about the services, they won't utilize it, and then all that money goes to waste.
This is Tom. I move to approve the proposed offering. I'm not including in the proposal that OEB elects to subsidize the 10 cents. think that should be voted on separately. But the proposal as outlined, I've moved to approve.
I'll second.
Okay, it's been moved and seconded. So we're just doing 90 cents, but without subsidizing for those in the 3-session model. Is that the motion?
Correct.
Correct.
Okay. Robert,
Aye.
Bill,
Aye.
Bonnie,
Aye.
Susan M,
Aye.
Susan R,
Aye.
JJ,
Yes.
Reed,
Aye.
Bob,
Yes.
Tom,
Yes.
motion carries.
Hey, Jeff, before we entertain a motion on the subsidizing, I just wanted to make a comment. I think that, you know, a 3-session plan, even if it's being chosen, is not overly effective for somebody who actually needs those services. So I think, you know, moving them to additional sessions is still a better value for them, even if it's 10 cents. I don't believe that we should be subsidizing that.
So are you suggesting we drop the 3-session option?
Oh, no. That's fine. If they want to keep the 3-session option and pay extra for it, more power to them. It wouldn't be a great move on their part.
There no longer is a 3 or 5 or a 6 session.
Oh, that's right.
We just voted for everybody gets 6 visits. Yeah. And Jeff, I think you're wrong when you say that that only the people who are paying for the 3-session get the subsidization. It subsidizes all of the entities.
Oh.
Everybody will pay not with the proposal. OEB can elect to subsidize $0.1 per employee for all entities who offer EAP. So right now we have one model, which is the 6 visits, and that with the digital, and at 90 cents, and that last bullet lowers it from 90 cents to 80 cents for everybody.
My mistake. Is there a motion to subsidize?
I would do the opposite. So no, sorry.
So I give a couple more seconds. Without a motion, it dies, right?
Correct.
Okay. All right, let's move on.
Jeff, point of order. I don't mean to be a stickler, but I'm going to be a stickler for Robert's rules. After a motion is made, there should be a call for discussion, which I think can also help flesh out some of these issues that we're seeing with the complicated motions, and then a call for the vote.
Okay. So we've already had the vote for the first part.
Yes, this is just be moving forward if we do another motion.
Okay. Okay, so we don't have a motion for subsidization. Nobody
We
made
just
a
move
motion,
on.
so that moves us forward.
Yeah, we just move on to the next subject.
Okay, well, so it sounds like we have the renewal approved for the EAP, which is good. RBH did provide an optional program for entities to select if they would like. So that's the caregiver options. So it's additionally, I mean, it's just essentially some help for employees who are, you know, either have adult family members at home that they care for, or even children. So it's just additional caregiver services, and it feels like
Rose,
that's just an option.
I think we're on slide 34.
Okay. Anyway, those are just options that entities can elect. It's certainly not something that is a, you know, it's not, you have to go with the caregiver. Each entity can decide. So it's a matter of whether or not the board wants to allow RBH to offer that service to the entities. And I don't know if you want to vote on that or just, I don't know.
Is there a motion for this? Without a motion, let's move on.
Okay, so that brings us to the Cobra administrative fee increase. I'm not sure what slide you're on, but so the Cobra, the BHS Cobra vendor who provides, you know, the Cobra package to folks and collects the premium and that kind of thing, that hasn't renewed in several years, and so they are asking for a 2-cent increase. And I don't know, Taylor, do you want to just provide a little more color to what's actually on the slide? But
yeah, happy to do that. Thanks, Jenny. So yeah, as Jenny mentioned, you know, this is kind of the first renewal in quite a while for Benefit Help Solutions, asking for a modest increase of 2 cents per employee per month. You'll see there on the slide, the 2% admin fee is listed as being returned to OEB. So that $130,000 annual fee really is closer to about $46,000 based on, because OEB gets the 2% admin fee returned, which is about $82,000. So for their renewal, they've requested 2% per employee per month increase. OEB still retains that 2%, which equates to about $87,000 for the renewal. We also did ask for pricing on a per continuant per month basis. Some employers will choose to pay their Cobra fees on a per employee per month, and others will choose to pay it as kind of Cobra notices are sent. The per continuant per month did come out to be significantly higher, so OEB is in an advantageous position by being under the per employee per month arrangement. So with all that in mind, we recommend the acceptance of that renewal. Are there any questions on that? I will also.
I had a question. I don't know anything about this. I assume that these rates are kind of industry standard and there's nothing unusual about it.
Correct. Yeah, we did look at some benchmarking, and that's kind of what spurred the conversation of, well, should we look at this at a per employee per month or per continuant per month? Right. So felt the fees were competitive, and then also, you know, with everything this year, there's just been a ton of Cobra activity. So sure. Benefit Help Solutions has probably surely been earning their money.
Yeah, I move to approve the proposed fees as outlined on page 37.
Okay.
Okay. Discussion. I see that smile there, Reed. Thank you. Okay. Call the vote. Robert.
Yes.
Bill.
Yes.
Bonnie.
Yes.
Susan M.
Yes.
Susan R.
Yes.
JJ,
Yes.
Reed,
Yes.
Bob,
Yes.
Tom.
Yes.
Motion passes. Okay.
There you go. Nice job.
Okay. All right. Well, I think it's time for a break, but I will take this opportunity to say this is the first time that OEB has approved all renewals at the first meeting in April. So congratulations. It's also, I think, the best renewal from a monetary standpoint that we've ever had. So congratulations again. Before we break, was there a comment? Did I see a comment? Hand go up? Guess not.
I would second that, Jeff. I just want to thank all the board members. That's great work.
And our consultants, and we really have forged a great partnership with our vendors. So it is 3:11. Let's get back together at 3:20 and we'll move forward with haste. Thank you.
Can you hear me at this point?
Yes.
Okay.
I can hear you.
I'm back on finally. All right. I'll go back on mute for a minute or two.
Grab one more thing here. Okay. Are we ready to go again?
Yep.
Let's go.
Okay. We have the Centers of Excellence update.
Yeah, and good afternoon. This is Margaret Smith Hsa, PEB OEB staff, and part of my responsibilities include staffing the innovation work group. And before I pass things over to Jenny to walk through the presentation, I just wanted to provide kind of a quick overview of what our ask is of the board today. So just briefly, going back in history to 2019, toward the end of the year, the Innovation Work Group undertook a pretty significant several month body of work looking at analyses of cost drivers. And one area that was identified in all of the data review was related to musculoskeletal conditions and procedures for those conditions. Coinciding with that analysis of utilization data, the work group also looked at a range of data on provider quality and had a lot of conversation around utilization, quality, cost, and the intersection of those dynamics. And one strategy that was identified by the work group to achieve the goals of both optimizing high quality as well as sustainable cost in care delivery was around centers of excellence models. So the work group has, over the past several months, done some preliminary work delving more deeply into centers of excellence, looking at kind of general frameworks for how a centers of excellence program could be approached. And before proceeding any further with any sort of more formal in-depth program development, the work group is coming to you, the OEB board, as well as they'll be making a similar update and presentation to the PEB board at their meeting later this month. Essentially sort of with the goal of giving you kind of the background of what has been done so far and asking for the board's concurrence that this body of work is something that the work group should continue with and should, today we're essentially asking that you approve the innovation work group proceeding with a more formal development of a Centers of Excellence program for musculoskeletal. And so with that, I'll hand it over to Jenny, who's going to walk through the detail, and we'll certainly then be happy to entertain questions.
Okay, great. I think I've got my computer back and everything's working. So let's just keep our fingers crossed on that one. But yeah, that was a really great summary, Margaret. In fact, everything you said is on this slide here. I mean, musculoskeletal has been an issue that OEB has been looking at on its own. And when we did the combined OEB and PEB cost driver review, it also bubbled up to the top. And so where it really, you know, that we've been talking about this for a while and through the innovation work group and talking about what are the things that you can do as a plan sponsor to help, you know, optimize that. Certainly the hospital cap, reimbursement cap is one way, but a center of excellence is really sort of the next step, next generation into a better cost and better quality program. And we're at this point focusing on musculoskeletal. So that's the highlight. We can go to the next slide and I'll give you a bit of a background about what went into the decision to sort of come to you today to say we want to continue working on this center of excellence and come up with a aligned strategy with PEB. So the first one on the far upper left is the spend and volume. So as we sort of saw at this at the annual utilization review this morning, you know, the healthcare spend in OEB, at least for these musculoskeletal procedures, is 4%. And it turns out when you look at both OEB and PEB, it's also about 4% when you combine all of our spend and all of the musculoskeletal procedures. At the time that we did this review, that represent, which was in 2019, we were looking at 2018 data. At the time, there were 1,300 procedures performed each year for back, spine, knee, and hip surgeries. And now at a more recent review, that's grown to 1,500 procedures. So certainly something to take a look at. If you go over to the right tile in variation and cost, one of the things that we did in the innovation work group is really did a deep dive into understanding what is the variation in cost of OEB and PEB spend for all these different procedures. And what you can see in this tile is that there is a pretty big variety in spend. Now, the hospital reimbursement cap will reduce some of this variation, but not all of it. I mean, some of the procedures are done, some of them are done in an inpatient setting where they could be done in an outpatient or ambulatory surgery center. There's some facilities that aren't subject to the cap because they don't meet the criteria or they're outside of Oregon, you know, in Southwest Washington or Idaho. So it's certainly something, it's certainly a way to get at the variation in cost. Probably one of the, if I go down kitty corner to the variation in quality, that's really one of the biggest areas I think of opportunity for a center of excellence is really understanding the variation in quality among the facilities that perform those procedures as well as the surgeons. And when we did some, again, deep dives into quality, we looked at, you know, where the surgeries were performed. And we do have some data, some outside data that provides quality scores at a facility basis. I kind of showed that, you know, 70% of the surgeries were performed in a facility that was in the 70th percentile for quality. And I guess that just means that 30% of them were not, you know, they were in a lower quality facility. Doesn't mean that those procedures necessarily resulted in poor outcomes, but if you're looking at a center of excellence or a way to sort of optimize care, a center of excellence would usually say something like, why don't we pick the very best performing surgeons and facilities and, you know, let our members know here's who these providers are, and we really want to incent you to use those because it's better outcomes, better quality, and most of the time lower cost. Kind of moving down to that complications, it's really a variant, I guess, or a component of quality. So we look at how many of these procedures have some sort of complication or readmission? Like, are we solving a problem that exists for OEB today? And so when we looked at the complication rate, it turns out that about 3 to 5% of those OEB surgeries had some sort of complication or a readmission. And that's pretty similar to what you see in typical employer-sponsored plans. But for those who put in a center of excellence or have a best-in-class rate, it's something lower than 1%. So again, tells us there's a little bit of an opportunity to optimize these procedures. Let's see if I go up to the opportunity to triage care. One of the bigger components of value in a center of excellence is a very formalized effort to help members get conservative therapies before going straight to surgery. And so when you have a center of excellence, the provider of that center of excellence, so in this case, we're going to be talking about carriers. So the carriers will, be coming up with an aligned strategy to really help educate members on the best conservative treatment before seeking surgery. And then once they do, if they need surgery, then you steer them to the best place to have it. And then finally, we'll talk a little more about savings opportunity, but so we spent a fair amount of time looking at how do you, what's the savings opportunity? Certainly there's a quality aspect, but the savings is also something that we want to pay attention to. And so there's savings that come from, that triage or reducing the unnecessary surgeries, lowering the complication rate. And for most centers of excellence, what they'll do in terms of reimbursements is to set a bundled rate, and the bundle means some services that happen around the surgery plus the follow-up care. And usually that bundle is something around 150% of the Medicare rate or lower. So lower than what our cap is today. So this is kind of the high level overview on why OEB and PEB should consider this. Move to the next slide. Okay, these next couple of slides are really just a little bit of extra detail on what I just talked about. So this is a quick snapshot when we looked at the quality scores, just showing you how some of these hospitals, for the procedures that we looked at, where the distribution and quality was. So on the left-hand side in that pie chart, you see that, almost 70% of the procedures were done in those higher performing facilities, and the yellow and red are kind of that lower level. So you want to look at the facility first, and then the next thing you want to look at is, well, how's the quality distribution, or what's the quality for the actual surgeon that's performing the surgery, because that plays a big part into it. And on the right, you just see an example of we pulled all the different surgeons that were performing these particular procedures at Salem Hospital. And again, so this wasn't OEB specific. This is just in general. You have a typical distribution. Some surgeons do sort of a better job than others, and there's a variety of reasons for that. But it's good for OEB and PEB perhaps to monitor that and steer folks to the ones that have documented higher quality. And what goes into those quality scores are, the complication rates, the readmission rates, the mortality rates, and they measure that over a specific period of time. Sometimes it's 2 years, sometimes it's 3 years, and sometimes it's longer. So this just gives you a flavor of how we would look at quality in terms of setting up that center of excellence. I'll just pause for a minute and see if there are any questions.
Jenny, this is Tom. You ended up use the word centers of excellence we would set up. Is the expectation that that OEB sets it up, or is it that we basically tell our medical plans, we need you to set up centers of excellence for musculoskeletal, and these are the criteria that we want you to use?
Yeah, that's a really good point. So I'll just give a bit of background. So there's 3 sort of traditional ways to set up that a plan sponsor would establish a center of excellence for a particular procedure. One is to just use, if a medical carrier already has determined who their center of excellence is, and they have a way to steer folks to those people in a formal program to support it, you could certainly use the carrier approach. And we did ask the carriers, where they were in that journey. 2 renewals ago. So not this renewal, but the year ago. The second way you can set up a center of excellence is to use a vendor that specializes in doing all of the quality work, the bundle payment negotiations, the quality monitoring, and the big component of that too is the member support. So vendors can do that, and we did through the innovation work group. We did an RFI to kind of understand what a vendor could bring to the value proposition for OEB and PEB in setting up the center of excellence. But at the end of the day, I think the recommendation from the innovation work group is to do sort of a hybrid of those two, which is the third approach. And that is, let's work with the carriers and try to use the, what we can as best practices as to what a vendor would do and how, and the formality of the way that they look at those programs and measure and monitor them and provide guarantees and savings and that kind of thing. But we're going to do that. We're proposing to do that with the carriers. I'll talk a little bit about the steps that we're proposing to go through in establishing that. But really, it would be the carriers doing a lot of the vetting and negotiation, and then OEB and PEB staff and consultants would help sort of make sure that the programs between the carriers, there's 3 different carriers here that we're talking about between OEB and PEB carriers, that everyone's doing it sort of the same way and using the same metrics and, aligning as much as possible in terms of the incentives and the reimbursement. Does that help answer that question?
Thank you. That answers my question.
Okay. Just go ahead and
This
go.
is Bill. I'll reiterate a comment that a big part of this kind of work has to be in a marketing of this to the membership at large, because they will see this very differently than how we're seeing it in this boardroom. It's very easy for a member who doesn't see the value in going after this on an individual basis to just say, you're just forcing me to travel to save you a dime and my rates still go up every year. And really we're passing value to the member by getting them to a better place, and it needs to be marketed well or it will go all wrong politically.
Yeah, I would completely agree with that. So the working with the member and ensuring that they find value in the program is really key. And so we've got a few reasons here on this particular slide. So that was a good segue into, what's in it for the member. And I think you're right. So I will say that when we looked at the vendors who specialize in this area, they end up having very good member satisfaction scores. And, so the key is going to be making sure that the carriers, include all of those member support services, because when a member, is looking to do knee surgery or their provider physician says, you really might be a candidate for this knee surgery. A lot of the times you either take the recommendation of the surgeon and just do whatever they say, but there's still a lot of unanswered questions like, how much is this going to cost me? What's my recovery time? How am I going to do all of that? And so that's where, providing some of that hand-holding and assistance to the member along the way really can result in some good scores. So for example, if the message is, hey, the reason that OEB and PEB are doing this is that we want to make sure that you're getting to a provider, a surgeon who's in the top, if it's 90th percentile or 75th percentile or whatever the mark is that OEB or PEB chooses to select, that's helpful to the member. And if you tell the member, we're also going to help, if it involves travel for you, there should be a travel benefit for you and a family member, and we should help you figure that out so that it's not stressful for you. But you're right, though, a lot of this has to happen ahead of time.
Yeah. If I might add a couple comments, Bill, I strongly agree with you that communication plays a major part here. Part of the reason for the innovation work group to lean in this direction was for us to develop centers of excellence closer to home. So potential travel is moderated. And also to improve the quality of healthcare in the state. So our carriers can leverage the relationships they already have and set standards and gain agreement that keeps care as local as possible. But I guess I would say that the strong emphasis is on quality, and when you're looking at musculoskeletal situations, if it goes wrong, that's a lot of times someone is not feeling well because having to redo things or elongate their care. So it really is a strong emphasis on quality and good outcomes.
I have a question on the centers of excellence and where, I mean, I'm 200 miles from Portland. So I'm only 30 miles from the Tri-Cities, 60 miles from Walla Walla, Washington. So, I mean, are they going to be cross state lines if necessary, or do we all have to go to Portland, Salem areas, Bend? And Bend is still 200 miles away.
Yes, no,
I'm in the sticks.
Totally understand. So there hasn't been any decisions, honestly, about who the facilities are going to be or where or how many, or whether they're all going to be in Oregon or whether there's going to be some outside of Oregon. All of that would be developed and determined in the subsequent meetings that we would have with the carriers. So at this point, we basically talked with the innovation work group and said, we think this is a great idea to explore. They said, we want you to get the OEB and PEB boards approval to go ahead and move forward with this. So the next step that we would do is to start meeting with the carriers, talking about here's what we want, because we haven't even done that really, but here's what we want to do. We want your help. Then they'll need to identify who's sort of the short list of facilities and surgeons. And along the way, and then Margaret, keep me honest here, but I think the goal is to come back to the boards and give a progress update as we go. Like, hey, we've selected some. If they're all within Oregon, then maybe the travel benefit is different. Or if one of the carriers says, we really think that we want to send members to, the Cleveland Clinic, that's just a really different travel benefit and model. So all of those decisions would need to come back to, I think, each individual board to solidify.
Yeah, and just to add to what Jenny noted, I mean, I think we anticipate that after today, should there, be agreement to continue with this body of work, that we would be looking at, a minimum of probably 12 months or so to really work through all of the decision making and the program development. And we could certainly get on a regular schedule where we're providing quarterly updates to the board, or whatever frequency makes sense in terms of progress on this, because there will be decision points along the way where the innovation work group will need to consult with the board and get your feedback and input on direction.
Yeah. That said, a center of excellence model really does usually mean that you're narrowing the available facilities and providers to a select few, because one of the criteria is to have a certain amount of volume that is gone through there. And in return for that, then the providers will provide the service at a lower reimbursement bundle.
Tom, you had a comment?
Yeah.
There's another comment, hand raised, from phone number ending in 43. Okay. Continue on, please.
I'm sorry. Go ahead.
Go ahead, Tom.
Yeah, the issue, I wanted to honor what Bonnie raised, and to make sure that as we move forward with this, that people understand the implications of centers of excellence. and particularly for things that are relatively common yet expensive, and they seem to do. People seem to do better in places where there is attention to quality and high volume. It raises the issue of a community, a moderate-sized community might have orthopedic surgeons around because they're able to do knee and hip replacements. And if that facility or those surgeons are not able to do those revenue positive surgeries, it means they're not there to be able to come into the emergency room and set a fracture. The reality of as medicine has become more and more complex, and the need for concentration of services is in high volume, high quality places it's a huge dilemma, and we need to make sure we go through this process, which I think we absolutely need to, with our eyes wide open, and because it will have its controversy.
There are two more hands raised.
Yeah, it looks like Bob. Bob?
Yeah, I've got a couple things I'd comment on. One is I want to make sure that we're putting our equity lens on this work, and that we're really thinking through what it means. So part of what I will need to see is I'll need to see a map that shows where these centers of excellence are. And this is to Bonnie's point of we need to make sure that this is an equitable process throughout the state. Second is there's another way to look at it. So one way to look at it is say, let's measure the quality outcomes and the excellence in all these different places, rank them and say, here's the ones that we're going to put at the top of the list to go have the procedures done. Another way to look at it is to look at what the qualities or characteristics are that's happening in those locations that are centers of excellence, identify clearly what those are, and assist some of the areas that may not have the same level of quality within their system, maybe for some reasons that can be fixed. And that way we can more equitably create the centers that can serve populations that are closer to their homes.
Bob, your second example is exactly what we want to pursue. Yeah, let's raise the bar in Oregon.
Yeah, oh, that would be the ultimate outcome, I would say. Okay.
May I add to that, Jeff? I don't know if you can see my hand up, but I just wanted to say that I echo Bill's original concerns and definitely those of Bonnie's as well. And I certainly agree with what Jenny said, that we should let our members know where these excellent surgeons are and who they are, and even incentivize them using them. But as you guys presented to us just a little bit earlier, in just a couple of years around the coordinated care, we moved people from 57% to 75% of their engagement. So why wouldn't we go in that direction? I mean, it may not move people as fast as we want, like it didn't there, but it definitely gives the people the options that they want to be able to choose the doctors that they personally trust. And I think that that adds to people's well-being and wellness when they feel comfortable. And usually that is at their home, around their family. I'd also be concerned around pandemics like we're in now. If you planned your surgery and now you're going to be in a hotel room or whatever it is, away from, you know, where you feel safe, that would be another concern.
And this is Sue Ricky Smith. Susan, I echo that. I'm sitting here thinking about the fact that today, by Friday, we're going to have counties that are going to be back in high risk. And so as we're asking these people to travel, they may be going from a moderate to low risk county, and then we're asking them to head into a high risk county or extreme risk county until we finally got everybody vaccinated at a level that'll keep this under control and have, you know, significant musculoskeletal surgeries, which either go amazingly well or not so amazingly well. And I'm clearly thinking about one of my own staff members who became septic. And this was a well-known and highly skilled surgeon. And so I'm thinking about what does that mean for a Bonnie who may have to travel and then end up having sepsis and now what, right? As well as exposure potentially to COVID. So I think it's something that's going to have to be in our thinking. And to Bob's point, relative to the equity of equitable services as well as outcomes, that's going to have to be top of mind in our thinking as well.
Yeah. So
This is
and
JJ.
all those. Oh, go ahead.
I just wanted to also echo some of the rationale of the innovation work group. Despite the fact that we had very favorable renewal this year, the reality is 3.4 is below market trend. It just is. And in order for us to consistently over time hit that number, the low-hanging easy fruit is gone. I mean, it just is. So the purpose of the innovation work group is find the hard stuff, find what we can do to save money. And some of that monetary savings is improving the quality, which I think is a win-win. But ultimately, we're in a position to make the hard decisions that may not be popular and may be disruptive, but are necessary to hit our 3.4 mandate. So that was kind of the thought, and we wrestled back and forth. I mean, your issues are 100% legitimate. There will be disruption. If we tell a member, oh, you're having a replacement, cool, you have to go far away, they won't like that. And that's the reality. But I think if we can say this is going to save money, and more importantly, the likelihood of greater risk is much lower, and the outcome is going to be 4 to 5 times less likely that you're going to have complications, that's something we could sell, and we do have to market it. But I think that it's part of the impetus of making the hard choices.
I'd like to say that all the concerns that are being raised are exactly why the Innovation Work Group is pursuing a customized approach, rather than buying an off-the-shelf model that's going to send people out of state and long distances. And so we're in the earlier stages, and we're going to be setting goals for exactly what it's supposed to accomplish. And your feedback today has been very helpful, that we want to make sure we check those boxes. And if we go back about 3 slides, which I'm not asking you to do, while there is dollar savings, the real compelling issues are that people get less than appropriate care. It prolongs their recovery. It reduces the best outcomes.
What's up?
And so we really want.
My meeting is almost over, but if you come in here, come here.
We really want the best quality care for our members. I'll just stop there. So hold us accountable for meeting your concerns in the future.
Yeah, that's good. And then the only thing I would say is that, and maybe this gets to the ROI slide that I was just getting ready to talk about, how the program, I mean, so we'll work, the idea is to work with the carriers to identify who the potential centers of excellence would be, who the surgeons would be, develop the quality metrics and how it's measured. And then maybe go one more slide, Rose. But the key to it is getting members to engage. And there are a couple of different ways to do that, not explicitly mentioned on here, but the main one is through plan design. So concierge and member service is one way, but plan design and incentive steerage is another way. So there are some programs that have made this a voluntary, like they just, let folks know, here's who our centers of excellence are. We would encourage you to use them, and here's why. There are other plans who have determined that it's best to use a benefit design to steer. So that means usually reduced co-pays or sometimes waived cost sharing if you can on a plan design to incent the member to choose to use that center of excellence. And then at the far end, some plan sponsors just make it mandatory because they know it's the best way. So all of those, so that decision point, at this point, well, that lies with OEB and PEB separately, right? So we're planning to come up with who they are, how do you measure them, what's the right way to go about it, and provide some suggestions for plan designs or incentive steerage. But at the end of the day, that's up to I think each board to determine what's the right incentive plan design for their program. What you see on this slide is, the amount of savings that you get really depends on how much participation or what percent of the surgeries are done through that center of excellence. And we modeled a few different scenarios here, just using some assumptions on plan design, steerage, and what the lower reimbursement is. But so that you can see, the more participation, the more savings. And so that may be important to get savings, or it may just be important to really drive quality and outcomes. And so, you want it to be more voluntary. Or you can do it as a continuum. You could start the voluntary and move either way. But those are all what we plan to do, is to, if you're approve us moving forward with this work, is to do all of the research and say, yes, we want to move forward, but the implementation really wouldn't be until October of 2022. October of 2022. On my next slide, I think. Yeah, let's go ahead and go to that next slide. I think we're almost there. Yeah, this is just more details about the steps that we would take, again, if approved, to go forward. And this just really gets you to that, first we need to establish the criteria, work with the carriers on determining who they are. Then they're tasked with contracting and making sure that they can meet the reimbursement requirements. Then about this time next year, the board would start to look at what would the right plan design and benefit design would be. And by that time, we should know who the facilities and surgeons would be, and where those would be, and what kind of travel would be associated with it. And then again, that's sort of the go, no go time frame. Like, yes, we want to do it, and here's what the benefit plan design would be. And then, move straight into member education so that it's ready to go for October. Lots of decision points still to be made, but that's the general time frame. And then on our last slide, we just kind of have the, who's responsible for doing what. And I talked about most of the, the carrier partners are going to be at this, again, in our structure, developing who the facilities and surgeons are and negotiating the reimbursement. OEB and staff and consultants will make sure that all the carriers are doing kind of the same thing, so that we're approaching it in the same way, or that the carriers are approaching it in the same way. And then the board is going to be responsible for sort of the overall recommendation and the incentive and plan. So that's the goal. That's the idea. And again, as Margaret said, what we're looking for is approval that it looks that this is a good idea to continue moving forward with.
This is Ollie. I would just echo what JJ said. I just think there's, what the innovation work group set out to do is find ways to become more efficient. So you don't have to consider reducing benefits, and find ways we can lower costs but improve quality and improve care at the same time. And this is really an option. I mean, this is all great feedback, and it's absolutely all true. But we think there are methods that we can use to ensure our members are well taken care of and feel like they're getting a value, getting the best surgeons. And if they do have to travel, then we make it worth their while. Bottom line is there's a huge difference in cost from one place to the next, and usually the more expensive, the lower quality is what we found around the state. So it's certainly worth exploring, in my opinion, and I really do appreciate all the great feedback.
Susan Miller.
Thanks, Jeff. Thank you to the Innovation Work Group for the work that you've done. You've really thought outside of the box, and that's that really shows. You've done really good work here. I have a question for Jenny. You said that you guys had looked at different programs where they did make it voluntary and then maybe moved from voluntary to not. Is that something that we could take a look at or get some information on how that works or who's doing that?
Yeah, I think that's going to be really central to the plan design or the incentive that OEB wants to take a look at. And certainly, if you want to take a look at those options ahead of time, we can do that. But I wouldn't envision that we would come up with, here are your options in one meeting and you have to make a decision. It feels like this would be a more significant study of work. Potentially could happen through CL or through the board, however OEB would like to see it. But yes, there are a variety of ways to set it up.
I think the next step for us is to set the standards that we're trying to achieve. And in part to help us do a good job with that, I asked Tom Siltabo to participate as a non-voting member in the Innovation Work Group so that we would have his expert medical advice as we look at those standards. So you get at least 2 more reports, if not 3, before we get to a final recommendation.
Yeah.
Okay. So the action is, are you in agreement that we can continue forward in trying to define and develop a Center of Excellence program? And I guess in keeping, well, I'll take a motion to that effect and then we can have further discussion.
So moved.
Thank you. Second?
Second.
Bonnie. Oh, fine.
Sorry.
No problem.
Okay. Discussion. If we need more.
I certainly understand the benefit of having the centers of excellence, and I just want to make sure that we think it all through. Is the travel going to cost us, X amount of dollars to get there and have a hotel for someone, and all the ramifications. So I just have some that are maybe out of state and local. That's my only thought.
Yeah, it's
But I certainly
so noted. Thank you.
And Jeff, this is Sue Ricky Smith. Ali, I absolutely resonate to the goal here. That's exactly what we should be doing. I only raise the other concerns as you're doing that work, but I am, since I've made the motion, I'm absolutely in favor of this work. I think it is the right work to do. I think it is driving towards excellence in general. And so I did not want anyone to infer that my comments were critical. They were simply other factors to consider.
So noted. Are we ready for a vote? Okay. Tom?
Yes.
Bob?
Yes.
Reed?
Yes.
JJ? JJ?
Sorry, I was muted. Yes.
Susan R.
Yes.
Susan Miller.
Yes.
Bonnie.
yes.
Bill.
Yeah,
Bill
but
left or
Bill had to leave.
Okay.
there was a note. He said he had to leave.
Okay, Robert.
yes.
Motion carries. Thank you. All right. Well, we're pretty far back, aren't we?
Jeff, I think we can probably push Brian's consultant report back to next month.
Okay, are we going to have a May
To say
meeting?
that To Ollie, this is Claudia. I was going to suggest,
Okay.
since it's just information, maybe board could read the presentation, but really next month would be much more mission critical to some of our timelines. So
Thanks,
thank
Claudia.
So Ali, will we move forward with the May meeting then, since we won't meet at the end of April?
Yeah, I mean, I think it's up to the board, but yeah, we would have just May and then June, and then have July and August off.
Okay. Okay, we need to discuss a mandatory open enrollment. Do you need that action?
Yes. Yeah, this is real quick. I have two things here. Due to COVID-19 last year, staff recommended that the board approve a passive open enrollment, so non-mandatory for OEB members, and staff recommends returning to a mandatory open enrollment for the 21-22 plan year, in addition to possibly, well, adding a new medical and dental plans. There are other important decisions for members to answer and update each year, including our verification of dependent eligibility, our verification of surcharges, verification of personal information, beneficiaries, plan choices, and dependents, and of course, flexible spending accounts, which always is a big one. So in summary, a second passive open enrollment, we feel like it would be more difficult if we waited another year to reverse that and go back to the way it was. And we also feel like OEB members are likely going to be better situated to enroll next year, whether it's at a remote workplace or back on the work site. So no board action is necessary, but just wanted to make sure that nobody had any real concerns or issues with that.
Yeah, especially since we got those two plans. Okay.
Okay.
Any questions of Ollie on that?
I have no concerns about this.
Okay. Thank you. And then lastly, you might remember like the last, about every 3 board meetings, we look at extending our testing and treatment of COVID-19, and the board approved Moda's proposal to waive cost share through the end of this plan year, and then extended it to March 31st. And just talking with Moda the other day, they're now extending the waiver of testing and treatment for COVID for their commercial insurance plans through June 30th. And they've offered this extension to OEB as well. And Kaiser right now continues to follow the timeline for the National Public Health Emergency, which is set to expire April 21st. So their 0%, their $0 cost share for testing and treatment actually would end on April 30th. And we're in close touch with Kaiser, and they said they would notify us if there is an extension. So what we'd like to do is first recommend approval to extend the waived testing and treatment cost share to Moda members through June 30th, and then to avoid an extension vote in the summer when you're not likely meeting, staff requests the board grant an automatic extension that aligns with book of business for both Moda and Kaiser. That way board action wouldn't be necessary.
Okay.
Board action is requested here.
Okay. Do we have a motion?
This is JJ, so moved.
Second.
This is Reed, second.
Discussion. Okay. Call for the vote. If I run out of sheets. Oh, I've got one more. Still in the coffee machine. Okay. Robert.
Yes.
Bill. Oh, he's gone. Bonnie.
Yes.
Susan Miller.
Yes.
I think Susan Reike Smith had to step out.
Yes.
JJ,
Yes.
Reed,
Yes.
Bob,
Yes.
Tom.
Yes.
Okay, we have enough. The motion carries.
Yes, thank you so much.
Well, with the postponement of that other report, we are ready to crawl over the line. Very productive meeting. Do we have any public comment before we close it?
No.
Okay, and Ollie, I haven't missed anything, have I?
Nope. Ton of work today. Great job. Thank you.
Yes, thank you all, board members. Really appreciate it.
Hey, Jeff, can I have 2 minutes?
Okay,
This is just a quick pitch. It doesn't require board action.
is this public comment?
Yeah, I can classify it as that. So this is a COVID issue. In response to COVID, we've had social distancing, mask wearing, contact tracing, and all that stuff. And the reality is those efforts have been marginally effective or ineffective, depending on where you're at. But most of the state will have full access to vaccinations for all pretty much everyone here in the next week or two. And frankly, a number of counties have almost full access to everyone right now. My public health director came up with a genius idea that I think would help advocate to help people get over their hesitancy. And that is to petition the state to change the qualification of metrics of restrictions to the vaccination rates. So once you get a high enough vaccination rate, the extreme classification is no longer accessible. And once you get to an even higher level of vaccination rate, the high designation is not even available. Because by definition, if 60% of your populace is vaccinated, you can't be in extreme. Most of your folks are already inoculated. So what those numbers should be, I don't know. He wasn't even sure. But that's an idea to help advocate people to get vaccinated, help push them over their hesitancy. And also that would be a tool for a lot of local governments, city councils, et cetera, who are somewhat wishy-washy in their advocacy, to have a tool to help their local businesses. And that would be able to foster a lot of folks getting vaccinated. So
That's an awesome
I
idea.
try
I
to-
brought that up at the meeting just the other day. That's cool.
And this is Tom. The science doesn't back you up all that in that entirely. What matters is case rates and percentage of positive tests. There are vaccinated is good, but you could be in a situation where you had relatively low vaccination rates that the disease has gone through and you'd never open up, even if your rates were your case rates were low. So my counter is that we have people in public health who are thinking about this 24/7 and have been doing it for a year plus. And the advocacy that you're raising, I think we need to do things to promote vaccination because it is the way out. But what you said about masks not working is also just not accurate, JJ. So
no, what I'm saying, I think masks are a great tool and they work, but
you have to use them.
Not chosen to use them.
Yeah, and you can't. Your comment requires if you're asking, you have personal comments, and I support you being able to talk about that. If your interest is for us to, as a board, to support what you just said, I have major problems with it. So I'm not sure what you're.
Now, what I'm asking is individual people, if you think this is a good idea or there's valid in fleshing it out, because it is a very rough idea, what I'm in the 2 minutes, to make that pitch to the sphere that you have. I know that there are people that are trying to influence whatever sphere they have, and so I'm trying to influence the small sphere that I have. I think that there's value in tying maximum risk levels, 2 vaccinations in conjunction with case counts.
Yeah, got to include the case counts. That also is, it tells us people in the hospital, people in ICUs, it all needs to be included. But you're correct in that we have to figure out how to promote vaccination. It's critical.
Yeah, and I could say I live in Southern Oregon. Southern Oregon has the least vaccination populace in the country. Now, this isn't specifically COVID. This is just in general. There's a ton of hesitancy from a number of different demographics that happen to live in a few counties in Southern Oregon. So my public health director spent a fair number of time over the years trying to figure out how to get people to overcome that. It's not an easy task.
Yeah, I agree.
That's all I have to take up a few minutes of your time.
Yeah, thanks, okay.
Thank
It's
you.
all about the incentive, just like Centers of Excellence.
Hey, Bonnie, can you stay on for just a minute?
Sure.
Okay. I will adjourn the meeting. Thank you. So done.
Bye, everyone.
Bye-bye.
Bonnie,